So without further ado, I'd like to introduce a friend of mine that I've been working with for where we just figured it out 7 or 8 years. Dr. Ganguly, I call him Sid, is now with the Houston Methodist Hospital, I believe, or Houston Methodist at Houston, Texas. And he started many programs across the country. So they're thrilled to have him down there, and we're thrilled to have him here today. So Sid, take it away.
Thank you, Kelly. It's a very nice introduction. Kelly and I go back, I think, more than 8 years. Out of your 20 years of service, which we all thank you for, we've been doing this regional workshop for the last 8 to 10 years in Kansas City. Before I delve into the Myeloma 101, just want to give you a little bit of background. Many, many years ago, I was actually trained from Houston Methodist and Baylor College of Medicine. And after that, I went to Kansas and worked there at the University of Kansas Center, developed the myeloma program for 19 years. And that's where I met Kelly, and we developed our myeloma program, a very strong myeloma and amyloidosis support group. Every year we held this very well appreciated regional workshop, but then COVID hit us and we did not stop. We did even last year virtually, because I think it is important to keep up with the advances that is happening in the field of myeloma, and all for the better. And then I moved to Houston, and I have been here for the last 4 months, and Kelly and I talked and said that we need to continue this tradition. We need to build a strong myeloma program here. And that's one of the reasons, and that's one of my mission and vision here at the Houston Methodist Hospital. And I've been here for 3 months, and I'm basically happy to say that I'm back to my alma mater, back to my home where I actually started my career. Without any further ado, we can go to the next slide. As Kelly was saying, that we do need to understand the Myeloma 101 to understand where we started and where we are going. So just to give some basics, which many of you already know, but some of you might have been introduced to this disease either through personal experience or family or relatives, and this is something new. Myeloma is a cancer of our immune system. The name of the cancer cell is called plasma cell. Normally, plasma cells make normal antibodies to fight off infections and foreign invasions. But in myeloma, for some reason, those plasma cells become abnormal. And when they become abnormal, they proliferate and they start making an abnormal antibody, which on the left upper panel, you can identify by doing a blood work called serum protein electrophoresis. And that spike with a star on top, that should not have been there. And that's what is called a monoclonal spike, or M spike, which is one of the hallmarks of having a monoclonal gammopathy, which multiple myeloma is one of them. It can be a full antibody, or as you can see in the lower panel, it could be just the light chain, which also we have the capability of measuring, especially kappa and lambda, 2 different types. And if the ratio is tilted, then it's also important to classify that as a light chain myeloma or light chain monoclonal gammopathy. When those plasma cells start increasing in number inside the bone marrow, then it eats away the bone. And you can see on the x-rays, the hallmark, what we call is lytic lesions on the skull, or it can eat away a vertebra and can cause a vertebral collapse or a fracture, and sometimes even can cause a long bone fracture. And these abnormal proteins can also plug the kidney tubules. And often I've seen patients coming to see me as a first manifestation when the kidneys are not working. So multiple myeloma is actually a multi-system disorder, and it can affect every organs of our body coming out from our immune system, and hence patients are immunocompromised and very high risk of infections, pneumonia, etc. On the right upper panel, you can see those large, deep blue cells, and many of them actually look very, very abnormal. And some of those cells may even have 2 nucleus instead of 1 nucleus, Next slide, please. Which can remind you of someone else. And that's, of course, a joke. Next slide, please. So the earliest evidence of myeloma we might have seen in one of the Egyptian mummies, where they had found out vertebral disease or plasmacytoma. Next one. But in the modern medicine, the definition of myeloma actually came from England, where this woman, very clearly depicted in one of the journals and the papers, where her bones were deformed, and one day she was in front of the fireplace resting with her husband, and suddenly she felt a snap in one of the thigh bones. Her husband picked her up, came to the nearest hospital, where unfortunately she passed away. And an autopsy was conducted, and the pathologist mentioned that the bones had a red grumous matter, thick and lumpy, which now we know was full of malignant looking plasma cells. She was actually treated. At that time, the treatment was not available. She was treated with orange peel and rhubarb. Of course, you understand, he did not do very well with the orange peel and rhubarb, but we have come a long way from that to today. Next slide, please. So multiple myeloma, unfortunately, in majority of the patients is an incurable illness. However, I must say, when I started my medical school compared to where I am now, I have been seeing at least 15 to 20% patients in my practice that we treated and did a stem cell transplantation and then maintained. And I do not have any evidence of myeloma 10, 15, 20 years. Are they cured? Maybe, but I'm using that word very cautiously. Most of the patients with myeloma start off with a relatively benign condition called monoclonal gammopathy, where the bone marrow does not have excess plasma cells. You can still see the M protein in the blood, but the patient has no symptom. As we get older, actually this MGUS is more prevalent. Almost 10 to 12% patients above the age of 70 or 75 may be walking around with a monoclonal gammopathy of unknown significance, because 80% of them would not progress. However, in some of those individuals, it does progress to the next step, where the bone marrow now has more plasma cells, and it spills into the category of smoldering myeloma, but still the patients are asymptomatic. But they still have a 50% chance, but some of them, which we call a high-risk smoldering myeloma, will eventually turn into a symptomatic myeloma. And you might have heard about the acronym called CRAB: hypercalcemia for C, renal failure for R, anemia for A, and bone lesions for B. Once that manifests, then we have a definition of multiple myeloma. Now, there are other newer definitions even without the CRAB. For example, the light chain ratio involved over uninvolved more than 100, or the bone marrow plasma cell more than 60%, or MRI showing more than 1 lesions, it still can be classified as active myeloma. And then the patient needs to be treated, and they go into remission and relapse, and eventually, because of multiple genetic aberrations and mutations, some of the patients can turn into refractory relapse and may even turn into one of the really aggressive case called plasma cell leukemia. I'm not going to touch on that. It will be Dr. Abinor who will be talking about the relapse refractory phases. Next slide, please. So again, what I was saying, when I was in the medical school, a definition and diagnosis of myeloma, an average survival was 2.5 to 3 years. But now, as you can see, the survival has improved over the decades. And now it is not unusual. As I'm saying, 15 to 20% of the patients were long-term survivors and maybe even cured. So next slide, please. And this improvement in the survival in patients with multiple myeloma has happened over the last several decades because of an explosion of research, new drugs, and advent of autologous stem cell transplantation in the 80s. And now we are in the era of cellular therapeutics with CAR-T, or bispecific antibodies or intracellular signal transduction inhibitors, we call them as IBs, like small molecules. So there are many targeted therapy with monoclonal antibodies and proteasome inhibitors and medications like lenalidomide, pomalidomide. It made a paradigm change in the treatment and outcome in patients with multiple myeloma, with improving overall survival. Next slide, please. So this is a slide where I explain that the treatment of myeloma is like a lawn care. Well, whenever I say that, eyebrows are raised, but look it up, YouTube. I have this video, it explains. Let me explain. Say, for example, 6-8 years ago, someone did not have myeloma, and they have a fantastic green lawn. I'm going to compare the body with the backyard. And then when the myeloma is diagnosed, say, for example, the bone marrow has 30 to 40% malignant looking plasma cells, the backyard has equivalent 30 to 40% surface covered with wheat. So we go to the doctor, myeloma physician, and the physician gives usually a triple therapy these days, like lenalidomide, bortezomib, dexamethasone in cycles, 3-week cycles, and which is akin to using a wheat killer to the backyard. After 4 to 6 such cycles, if we happen to do a bone marrow biopsy, I can tell you the bone marrow would look better in majority of our patients. This is called induction therapy or inducing remission therapy. So the backyard now looks better. Maybe few dandelions and wheat still standing, but it is far better than before. If we want a deeper remission, we go to the next phase called consolidation. And in a transplant eligible patient, we do a stem cell transplantation. So the previous oncologist has done a fantastic job, and I would call that a master gardener. But now we need a lawn renovation, a new grass seed, a grass sod. So what we do in that situation, in a transplant eligible patient, step 1, we collect stem cells from the blood. The stem cells are usually in the bone marrow. We have a means to get them out from the bone marrow by an injection treatment, and we can filter out the stem cells very simply from the blood and put them in a plastic bag and put it in the liquid nitrogen freezer to use later. Lawn care story, I just collected the grass seed from the backyard, put it in my garage. Now the real transplant. We do a high-dose chemotherapy, consolidation, that will not only clean all the residual myeloma cells in the bone marrow, but it will clean the old but normal cells to make space for the new stem cells to grow. And the next day, we take out that stem cell out from the freezer, thaw it, and put it back through the line, just like a blood transfusion. And the stem cells will go and take foothold in the nicely cleaned bone marrow. And it will take around 2 weeks for the stem cells to grow. During that 2 weeks, usually patients are in the hospital or very, very closely monitored. And after 2 weeks, the bone marrow will be repopulated with healthy cells, hopefully without the malignant plasma cells. So what we just did to the lawn, we collected the grass seed, we nuked the backyard, hoping all the dandelions are gone, including some of the roots are gone, but the green grass is also gone. Well, don't worry. We reseeded the backyard with new grass seeds, and it takes 2 weeks to grow. Now we have a fantastic bone marrow with deep remission and a nice backyard. That's the consolidation. Now, if we do not do the transplantation, we can intensify the induction or continue the induction for a deeper remission, but no lawn can be maintained without a strong maintenance program. So after that, we need a maintenance so the cancer does not return. And that's why I call it stages of myeloma treatment, where the tumor burden goes down, 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 and we continue the treatment through induction, consolidation, aka stem cell transplantation or lawn renovation, followed by a maintenance therapy. Next slide, please. And by doing that, what is our goal? Our real goal is cure. And that's my dream. Maybe during my lifetime, I'll be able to see increasing number of the patients getting more and cure. But to get there, we try to get to something called minimal residual disease, or MRD negative status. The MRD negative can be identified by a multi-parametric flow cytometry, which we have in our Methodist hospital, or we can send it out for next gene sequencing, which actually can identify 1 in a million cancer cells, NGS. If somebody is MRD negative, clearly closer to maintaining that for longer duration, we call it prolonging the progression-free survival, or PFS. Next slide, please. So the question is, how do you use all these drugs or medications that we have now at our disposal? The questions are, do we use 2 drugs, 3 drugs, or 4 drugs? Which 3 drugs? And which is the 4th drug? Roll-up transplant, maintenance. And the big question that I asked almost every day is, somebody who is in remission, is on maintenance, how long do we continue? And are we close to the cure? Next slide, please. So this is an elegant study by Swag, which compared a 3-drug with 2-drug. The standard 3-drug with lenalidomide, bortezomib, and dexamethasone, called RVD, compared to len-dex only. And you can see from these survival curves that 3-drug was better than 2 drugs. So in majority of my patients, if someone can tolerate 3 drugs, we usually use a triplet. That is the standard of care in 2021 for newly diagnosed patient with multiple myeloma. Next slide, please. So then comes the targeted therapy, the monoclonal antibody, our 4th drug. So myeloma cells, or any other cancer cells, they have surface molecules, and one of the surface molecule in the plasma cell is called CD38. And in CD38 directed antibody, daratumumab, isatuximab, those are the antibodies. When given, they will go straight to the myeloma cells and invite the rest of the immune cells to kill the cancer cells. So really, daratumumab and the isatuximab and elotuzumab, these type of monoclonal antibodies have shown remarkable response in patients with relapsed refractory myeloma, and now they are being used upfront as well. Next slide, please. So this was the Maya trial, where daratumumab was added to lenalidomide, and it's called DRD, compared to a doublet, RD. Now remember, this one was used in patients who were transplant ineligible. That means we're not planning to take them to the transplant. Next slide, please. And one can show that adding daratumumab to the Revlimid and the dexamethasone, it improves the median progression-free survival. But on the right side in the table, you can see even the responses, the deeper responses with complete and stringent are better on the daratumumab group. So it's perfectly all right to consider adding DARA-RD in a newly diagnosed myeloma when you're not thinking of taking to the transplant. Next slide, please. So the question now is, how about patients that are transplant eligible? Now there are quads beyond the triplet. This is a trial called Griffin trial, which I participated when I was in Kansas. And presently we have given some updates where data was added to the backbone of RVD, which I've shown you, which is probably one of the standard of care triplets for newly diagnosed myeloma. And these patients, after the DARA-RVD versus RVD, were transplanted, followed by consolidation with few more cycles of DARA-RVD or RVD, and then the maintenance. The maintenance was either DARA with lenalidomide or lenalidomide by itself. Next slide, please. Now, this is a very new trial, so we are estimating its responses right now, but the overall survival or the progression-free survival data, we may have to wait for a few years to get that data. But whatever we have now, we can show that the depth of response at every step after the completion of the induction, post-transplantation, post-consolidation, it continues to fare better in the data RVD compared to the RVT. However, data RVD is not approved as of yet. Now, data with other combinations like VMP and other things have been used in Europe quite often. So data has been used upfront, but just wanted to let you know that Griffin is not ready for an FDA approval yet. Next slide, please. So the other question that we get asked is how long to continue that treatment if somebody is in remission. So this was a trial called FIRST trial, where there were 3 groups of patients where the chemo in this particular one is Revlimid and dexamethasone, which usually we do not do these days. We do triplet, but you can get the message out of it. Either we do it continuously or we do a predefined like 18 cycles or 18 months and or MPT. Now in United States, we do not use MPT often. Next slide, please. And here you can see that continuous treatment actually improves your chance of remaining in remission, progression-free, compared to stopping the treatment. So if somebody is not a transplant eligible patient and wants to continue, what I would do, I would VRD for 8 to 10 cycles. And then once they are in very good remission or complete remission, I probably will drop some of the triplets and continue the treatment indefinitely until the disease either progresses or there is some side effects emerging. Next slide, please. So with all these advances, is autologous transplantation still valid? The answer is yes. Next slide, please. Whenever there are new drugs coming out, we always try to compare that with autologous transplant. And every time we tried that, the progression for survival shows the auto transplant is better than continuing chemotherapy. So again, I'm re-emphasizing in a transplant eligible patient, I would recommend a stem cell transplantation. Now, if the patient is not transplant eligible because of comorbidities, ages, and other things, then it's perfectly all right to use all the novel drugs. This particular trial was from Europe that had CyBOR-D followed by transplant, then VMP, continuous versus transplant and maintenance. Next slide, please. The summary of this is the progression-free survival was better in the transplant, the remissions were better, and the best part is it was good for both standard risk and high risk genetics, which I will be touching upon a little later in my slides. Next slide, please. So the summary of this is upfront transplant significantly prolongs progression-free survival. You know, someone may say overall survival advantage. We have not seen that in this trial yet. And it does improve the response. And we would recommend in younger fit patients consideration of the stem cell transplantation as a consolidation, as a lawn renovation after the initial induction. Next slide, please. So the other question is, my doctor told me my myeloma is in good remission. Can I delay that transplant? And that was answered by this next trial, please. Next slide. So this was, next slide, please. This is a French and US combined. The French part is already completed and published. The DFCI, the US part, has already collected the data. Here, patients were randomized into 2 groups, RVD, stem cell collection, either transplant or just few more RVD, and then LEN maintenance. So one group got transplant upfront, the other is later in case the disease relapses. Next slide, please. Here, the message is again clear. Patients who got upfront transplant, their progression-free survival was better. Their MRD negativity was better. Next slide, please. So the second analysis demonstrated that transplant is associated with the mortality was in the range of only 1%. So it is very well tolerated and is associated with improved progression-free survival. And overall survival is difficult to draw conclusions because many patients actually went into second time transplant, and then we need longer survival, and the new drugs are coming. So even in the era of the new drugs, transplantation remains the standard of care. Again, I have to use the phrase in younger, fit, transplant eligible patient. Younger does not mean chronological age. I've transplanted age 81, but those people are really fit, like a cross-country runner would beat me any day. Next slide, please. So this is, next slide, please. This is talking about the maintenance, and which I already stated, unless we do the maintenance, there is always a risk of the disease coming back. And lenalidomide maintenance now is a long-term, shows every year we look back, patients who are on len maintenance, the overall survival and the myeloma risk is far less if somebody is on maintenance compared to non-maintenance. Now, of course, maintenance is tricky. We need to monitor for the low blood counts. There is a risk of blood clots. So patients should be on some form of prophylaxis with aspirin or a blood thinner. And there is a risk, something called second primary malignancy, other cancers. The incidence of that is around 4 to 6%. Now, the absolute risk means 95 to 96% chance that you're not going to get a second cancer, but 4 to 6% may, and majority of them are actually in the bone marrow. So my patients who are on maintenance, I do monitor their disease MRD status and also for the second malignancies almost annually or every other year. So if you are vigilant, then those risks could be abrogated. Next slide, please. So I touched upon the risk of the myeloma. So there are genes, chromosomes, by doing either a FISH or cytogenetics, we can classify them between the standard risk or high risk. Among the high risk, deletion 17p, p53, 414, 1416, translocate. These are the high risk genes inside the plasma cells. Now, they are not in the body. They are not being transferred from family to family in the generations. They are only in the cancer cells. Think of these as the roots of those dandelions. And hopefully by the treatment, not only the dandelion will die, maybe the roots will die as well. Next slide, please. So based on the risk, it has been shown that if somebody has a high risk, proteasome inhibitors and nowadays monoclonal antibodies sometimes actually helpful in choosing a treatment both in induction and maintenance and consolidation. So this is a paper from Emory where actually instead of just a single agent lenalidomide maintenance, they used bortezomib lendex maintenance and showed a fantastic 3-year above 90% survival even in patients with deletion 17p or high risk patients. So in my practice, if somebody has a high risk genetics, I would recommend not only just a lenalidomide maintenance, but also a bortezomib combination maintenance. So maintenance is something little more aggressive in high risk patients because the relapse risk is high. Next slide, please. So another question is, how long do we continue the maintenance? Right now, the recommendation, and I'm a part of the ASBMT myeloma guidelines committee, we say as long as the disease does not progress or if there is any untoward side effect, patients should be on indefinite lenalidomide maintenance. But some of my patients are MRD negative, no sign of any myeloma. Do they really need maintenance? We do not know that answer, but people have been trying to abbreviate the length of the maintenance. And this particular trial, again, we were part of it. Next slide, please. Here, initially, the patients were treated with Lendera maintenance. And if somebody is MRD negative after 2 years, they have been randomized to either continue the maintenance or stop. Now, of course, we do not have the data yet, but the message is if you are MRD negative and a persistent MRD negative, not just one-time snapshot MRD negative, then there's a possibility that we may stop the maintenance and monitor you like a hawk. Vigilance. But this answer is not there out yet. Next slide, please. So this is a very visual slide. It basically shows deeper the remission, longer the progression-free survival. So my goal is to get to not only complete remission, but stringent complete remission and eventually MRD negativity status. My last slide, I think. This is my most favorite slide. This is called a relative survival ratio. What is relative survival ratio? Just to give you an example, according to the age, sex, ethnicity, if, say, for example, I'm in upper 50 and I'm supposed to live for 30 more years based on my characteristics. And if I live up to another 30 years, then my relative survival ratio is 1. Okay, so that's the population survival ratio. When a patient is diagnosed with myeloma, as I told you, when I first got into my medical school, 2.5 to 3 years, patient would be alive. So the relative ratio right away at that time was 0.1. But then we advanced. We identified lenalidomide, proteasome inhibitors. We did transplant and maintenance. And as we achieved complete remission, stringent complete remission, more and more patients are getting it, they're living longer. The median survival is going from 3 years to 6 years to 8 years, gradually increasing. And then the maintenance and the relative ratio is now with the transplant, and this data is from Arkansas, is almost approaching the relative ratio of age and sex matched population. This is the reason why I do what I do every year. This is the reason what I did for 19 years in Kansas. And this is the dream that I brought here in Houston, so that with everybody's support, I can push the envelope with clinical trials. We opened already 8 clinical trials. 3 of them are myeloma. Hopefully by end of fall, we'll be rolling it out for our patients in this chapter. And with your blessings and with your support, hopefully one day we can say majority of the patients of myeloma would be cured. Next slide, please. And that's my summary. Right now, 15% patients of myeloma are cured. And my goal, my dream, maybe we can go higher. And if somebody is transplant eligible, refer to the transplant. And risk stratification, personalized medicines, immunotherapy that Dr. Abnor would be discussing holds a promise for future. Next slide, please. And this is where we were. This is where we are going, from chromosome to genes to future. And last one. And thank you, all of you, for welcoming me back to Houston. And with your blessings and support, hopefully I'll be able to do something good for the community.
Sid, that was fantastic. Can we go back to this last slide of Sid's presentation? That is a fantastic slide. When I started in the early 2000s, I would go out and visit support groups, and I'd have an index card where I used to use for studying in college. And I flipped it over before I went on my meeting. It said thalidomide, and I said, oh my goodness, I'm in the wrong world. This isn't what it's supposed to be. And now what I've seen happen over these years, these 18, 20 years, the future is awesome. I don't even know what kind of words to use, but Sid, what a fantastic presentation. Thank you. You covered a lot of topics for people, and I appreciate that.
And I thank Dr. Abnor and others. I saw that there were a lot of questions coming while I was speaking, and Dr. Abnor and others were answering. So really, thank you for that.
Well, one thing that came up that they answered, let's see, dexamethasone. Is it feasible to eliminate dexamethasone from some treatments? Rafat said dexamethasone is important in the first few months of treatment. And I want you to, can you expand upon that a little bit, Rafat?
Yes, of course. Of course. Oh, sure.
I mean, so there are actually clinical trials to show that continuation of steroid actually reduce the benefit of the regimen. So when somebody have a lot of myeloma, a lot of side effect related to the myeloma, I think dexamethasone can be helpful as part of the induction treatment, the first 3 months of treatment. But after that, there's really no clear evidence that it's very important. I mean, I think we have, if you're continuing therapy, for example, with Revlimid Dex forever, it's actually inferior to that if you just continue Revlimid alone. So I think it's just initially probably will be important to help with side effect and things like that. But we sort of went to this dexamethasone forever, and I don't think it's the right approach.
I totally 100% in support. Usually also the dose of the dex, which in younger people who can tolerate 40 milligram once a week, first of all, we don't do high dose dex. That is out. We do low dose dex. Yeah. Even 40 milligram once a week, could be a lot for someone who is frail and elderly. So we definitely decrease the dose to 20 milligram, and we would not use for more than 3 to 4 cycles. And after the maintenance, just single agent len maintenance for high risk patients, len plus bortezomib, and you can drop the dex right away. So lowering the dex and giving the dex in a way so the quality of life is kept intact is the most important thing.
Rafai, you said you wanted to answer that question. It just popped up. Go ahead.
So there was a question about somebody who had a stem cell transplant in 2006. It was diagnosed in 2006, stem cell transplant in 2007. They collected enough stem cells. They're still around. So yes, the answer is that those stem cells are still good, and they will be good as long as they are really in controlled environment, monitored 24/7. The temperature doesn't go below a certain level. So we have data from Hal Braxmeyer here, who looked at cord blood he stored 30 years ago, and then when he thawed the cord blood, the cells still were very active, producing white cells, red blood cells, and platelet. So as long as the patient is alive, the stem cells should be stored.
That is correct. And then we also check the stem cells viability before infusion. So just there's a double check and making sure, and majority of the cells, they maintain.
Okay. Sid, you want to talk about the COVID vaccination as it reflects to, or as it is part of the myeloma journey today?
So for some reason, I cannot see the questions. I don't know where I click. QAIMF.
I think it was, how do you know that the vaccine is working?
Right. So this is a question that actually being addressed by many trials that you are doing, if the vaccines are working or not. So one of the things that we did in Kansas City is we tested the antibodies, the anti-spike antibodies. And the vaccine response is definitely not as high as in healthy, no other comorbidity persons. But we still recommend vaccination because we do see antibody presence and persistence, especially after 2 and now with the booster vaccinations. So it may not be very high in patients who are immunocompromised, but I would still recommend that something is giving some protection, and we must continue the vaccine effort, including the boosters in our immunocompromised population.
Yeah, I mean, I agree. We've been following the antibody against the spike protein, and some patients who receive certain treatments or a very intensive treatment with anti-CD38 antibodies are losing the antibody response. So we try to adjust the treatment, revaccinate the patients. I think I agree that every patient should be vaccinated, and when it's time to get the booster, they should get the booster. Sometimes what I do is I recommend after the vaccine is that, for a couple of weeks, we don't use very high dose steroids or an anti-CD38 antibody to try to preserve the immune response.
Okay. Anne, how are you dealing with this in your clinic with respect to the shots and so forth?
We are recommending the COVID vaccine, obviously, to all our patients, and also the booster shot as well. And as was mentioned, we are recommending not using or avoiding dexamethasone for a short time afterwards. But yes, we are recommending, but we're seeing the same thing. Some patients who we are testing for spike antibodies are not showing signs of detectable COVID antibodies.
Great. We do have a question there. It says, when the stem cell transplant is complete, how do I interact with those who hadn't taken their vaccines?
You want to take that one?
Don't interact.
Yeah, don't
Stay away
interact.
from them.
If you want to interact, social distancing. I ask my patients to wear a mask and don't sit down and eat with somebody who's not vaccinated, because the longer you are sitting close to somebody who's not vaccinated, the more likely you're gonna get the virus. And the question is, are you gonna able to handle it, or you're gonna get flu-like symptoms, or you're gonna end up in the ICU on the event?
So the person who wants to interact must be a family, friend, colleague who cares for the post-stem cell transplant patient. And if that's true, then they should be vaccinated. They should go out and get vaccine to interact with the loved one. That's what I would recommend.
Well, considering that what we just talked about, this is kind of a general question. I think we should go back to the slides. What do you think if I've been diagnosed with smoldering myeloma, but have the TP53 17p deletion?
Okay, so this is a very interesting question. So the smoldering myeloma field is moving fast. I would say 4 or 5 years ago, we all recommended patients with smoldering myeloma should be followed closely, but they do not necessarily need treatment. Nowadays, we are moving, identifying those patients with smoldering myeloma that tend to be high risk, meaning statistically 80% of them would turn into myeloma over the next 2 years. They might benefit from early initiation of lenalidomide-based treatment. And who are those? Majority of the trials have corroborated the clinical criteria called 20 to 20. That means the ratio more than 20, like an involved over uninvolved, the M protein more than 2 grams per deciliter, and bone marrow plasma cell more than 20%. That had been included in majority of the trials to classify as high risk myeloma, and intervention in that particular group has shown clearly survival advantage, at least in the PETHEMA Spanish trial. And we had something called ASCENT trial that we are running, actually taking them even to the stem cell mobilization and collection. P53 definitely puts a high risk, not only P53, 414, 14, 16, they are considered to be high risk. And if they are in the 20 to 20 category, they should be talking to their myeloma specialist for early institution of therapy. But if they are not high risk, but they are P53, but not by the markers, then they should be monitored very, very carefully. So for example, somebody has 12% plasma cells, 17p, and the M spike is 0.5. I would not initiate treatment just because somebody is 17p, but I would monitor them very, very vigilantly. This is almost like CLL patients, as you know, chronic lymphocytic leukemia patients, stage 1, if they're 17p, I would not treat them, but I would monitor them very carefully because they will spill to the symptomatic disease any day.
I second that. I mean, I think it's very important not to treat the genetic abnormality, especially in the story was the 17p deletion is really not very well understood, because when you have deletion of the long arm of chromosome 17, that is not the problem. It's the problem on the other chromosome 17, because we always have two chromosome 1, 2 chromosome 2, 2 chromosome 17. If you lost the long arm of one of the chromosome 17, that's not the problem. It's the problem what's on the other chromosome 17. Is it a mutated TP53 that lead to your problem? And not everybody who has 17p deletion is high risk, so you need, so I think clinical monitoring carefully, like you heard, is very important, but don't just panic that you have a 17p deletion. I think close monitoring is very important.
Yeah, treat the patient, but not a result on a piece of paper.
Well, I agree with that a lot. Anne, would you like to add anything to what the doctors have been speaking about before we go on to the next segment?
No, I mean, we also do not treat smoldering myeloma, that's 17p. We just watch them very closely. Same kind of procedures.
Okay. Any gentlemen, would you like to add anything else to that?
I have a quick question for Dr. Abnor, and in your clinical practice, not in the clinical trial, have you started treating 20 to 20 smoldering myeloma patients, or are still waiting for more data?
Well, I actually, I don't believe in treatment that is intended to push the count down the road. So if you look at Revlimid in, for example, as a single agent or with steroid in patient with high risk smoldering myeloma, really, I mean, what you're doing is you're delaying progression. I believe if you want to treat, you should mean it and you should cure the disease. So I think the International Myeloma Foundation was the leader of the ASCENT trial. We finished accruing on the ASCENT trial. We will find out if an induction consolidation and a maintenance 2-year therapy is very important or not. And if this trial pan out, then I would say to my smoldering myeloma, listen, we're going to be aggressive, but we're going to cure you. We're going to get you into MRD negative that is sustained. But outside a clinical trial that meant to cure, I would just be hesitant, because I mean, I think it's not a walk in the park to be on therapy for a long time, because you've been seeing myeloma for more than a couple decades, and they can smolder for a long time. And when you put them on therapy, the cost, the quality of life is not the same, is it? And so I like an open-ended treatment. I don't believe in treatment forever. So I would like to see more a clinical trial to prove to me that intervention is meaningful.
Fantastic.
Saying that.
All right. Well, that was the last question for the moment. I would like to go into our next segment. Thank you, the panelists, and Ann and Sid. And Sid, thank you for your chat.